Let's talk about over-the-counter access to contraceptives. The first thing we'll go through is around the world overview of thoughts about this. And then we'll go through some of the literature on why this is or is not a safe thing to have and some of the reasons that people advocate for that. The recent news that we got was the FDA has approved birth control to be over the counter. When we're discussing birth control in the context of today, what we're discussing is hormonal birth control. Birth control pills are already over the counter in a lot of places around the world. If you look at this map, all the light orange areas are places where you can get birth control over the counter. I don't know the specific contraceptives that are over the counter in these places, but it is a lot of places, right? So you can already kind of infer by this that it can't be so unsafe that it's not something that is reasonable to do. Dark orange places are prescription only, and I do think it's interesting that most of the places where it's prescription only there's a pattern here, isn't there? Of the places where we're prescription only. So it's interesting to me. It's just something to note. I don't know what the distinction is, like why some places do and don't make it over the counter, but there you go. That's that map. Oh yeah. So Karen, my production manager, pointed out the same trend that I just said, which was interestingly, most of the highly developed or wealthy countries don't have over the counter birth control. So who does it affect? Well, I think we have pretty good data, and most of you probably know that a whole lot of people who have the need or desire to be on birth control, whether it's for contraceptive purposes or for treating other conditions. Now, the approval of the progestin-only being over the counter is technically intended for contraceptive use, but obviously people use it for many different reasons. So let's look a little bit at contraceptive use in the United States. You can see here. So this is from Gutmaker. If you ever need a reliable source for information on abortion or reproductive health care of any kind, this is a reliable place to look for information. 46 million U.S. women aged 15 to 49 in 2018 were sexually active and not seeking to become pregnant. Why is this important? Well, that means that they need some form of contraception. In 2018, 65% of U.S. women aged 15 to 49 were using some kind of contraceptive method. Now, these are interesting facts. I'll just go through them with you. So sexually active couples who do not use any method of contraception have about an 85% chance of experiencing pregnancy over the course of a year. That is very high, particularly if you're not interested in becoming pregnant. And it's very problematic, particularly given the state of access to termination care in the United States. Average number of U.S. children that adults think is ideal is 2.7. I don't know who's having 0.7 of a child, but good job. I'm kidding. I understand how averages work. To achieve that family size, a sexually active woman must use contraceptives for roughly 3 decades. That, I think, is a very important note, okay? So even people who do want kids, and they are not everybody, but even people who do want kids, have to use contraception at some point if they're going to be sexually active because, well, we all know. I don't have to explain this, okay? Basically, she's just written in there that a whole freaking lot of people use birth control, and that is important. Things we've talked about before, right? So we know that the next step for a lot of very religious people, and I actually just listened to a debate about this. I think it was Vosh talking to someone who's Catholic. I had many things to say about two people who don't have a uterus debating on whether contraceptive use should be allowed or not. It was mind-boggling that whoever put that together wouldn't choose, like, I don't know, someone who has a uterus. Not that, don't get me wrong, I think anybody can discuss contraceptives and the utility of them. And I also think there are many people who don't have a uterus who are affected by access to contraceptives and things like that. I just think it's a bit short-sighted to have a whole debate around whether contraceptives should be used or not and never get the opinion of somebody who might ever use hormonal contraceptives. Over 1/3 of hormonal contraceptive users say they've had gaps in pregnancy prevention or self-discontinued their medication solely due to issues with prescription access. This is a study that was in the Journal of Women's Health in 2016. And we talked about this a bit in the last stream that we briefly covered, kind of why birth control needs to be over the counter, at least in some regard. And I want to just show you the study. So this is people who are at risk of unintended pregnancy. Now, to get a basis for this, we know 50% of pregnancies in the United States are occurring in people who weren't intending to get pregnant. Now, that doesn't mean they're all unwanted or that all of those are ones that people would seek to end. I have a whole lot of patients who tell me, I'm not trying, but I'm not preventing. If it happened, it would be fine, but it's not something that I'm like actively, seeking to do, whatever. That's perfectly fine. But when you are in a group that doesn't feel that way, then having an interruption to your ability to get your contraception is very problematic. A third of women in the US have said that at some point they had a problem getting their prescription. I really think that this study must underestimate the number of people who have had trouble obtaining their prescription, because this has happened to me more than one time, many times actually. And if it happens to me, somebody that could literally, although I try not to self-prescribe, I don't prescribe medications to myself, but if it could happen to me, someone who could quite literally prescribe the medication to myself if I absolutely had to, then it can happen to anyone, right? And it is happening to anyone. And it's concerning to me that people don't see this conclusion and think, wow, that is alarming. This should not happen. Especially people who think that abortion should be illegal. Because if you truly would like people to not have abortions, and that is your true goal, your true north is abortion bad, I think, we should not have them, then why would you not just put front and center this number and say, please make contraceptives over the counter? Now, let's talk about some of the concerns that people have. And again, I think that most of the concerns that people have are legitimate worries that have been thoroughly addressed by the literature. I'll go through chat to address some of these concerns, because I'm sure that the concerns that I bring up here are going to be things that you will immediately come up with in your head. Lack of counseling on relative efficacy. Okay, great. I said all of these concerns, will be addressed. And the first one you throw at me is one that I wasn't prepared to address with literature. Okay. So yeah, lack of effective counseling on efficacy. I think that's a good point. I think that most contraceptives will have a discussion of that in the package insert. Most people who seek to use contraception know that it's not 100% effective. And I would say that they always, if you make birth control over the counter, should be provided with an effective and easy to understand list of efficacy and what affects that. Thank you for throwing at me the one thing that I had not prepared to discuss today. I think counseling is important, efficacy discussion is important, but I do think that can effectively be done with the information that's provided with the medication. Okay, great. Forsaken A96 says, the user may not be a healthy candidate for pills. This is a very common concern. I think well-meaning, but not really based in actual data when we look at it. So first off, many easily accessible medications have much higher side effect profiles than contraceptive pills. Second, every single risk of hormonal contraception is increased by a factor of 2 to 10 or more if you are pregnant. So blood clots, increased with hormonal contraceptives that contain estrogen, but increased drastically more than that with pregnancy. Okay. So you must weigh the risk of the medication. Obviously that makes sense. And we can go into the overall safety profile a bit too, but you're not really just looking at what is the risk of the medication itself in a vacuum. You're looking at what is the risk of the contraceptive medication itself compared to what that prevents, which is pregnancy, which is way higher risk of all of those things that we worry about. So we also have very good data on this that says people are able to effectively self-screen for if they are a good candidate to safely use hormonal contraceptives with a screening toolkit, which is just like a questionnaire, and that they'd screen themselves definitely as good as a doctor or healthcare provider who would have been providing the prescription. And in some cases, maybe even better, because sometimes that is not even something that is discussed when they go in to get a prescription. So let me show you a couple of the studies on this. So accuracy of self-screening for contraindications to combined oral contraceptive use. Now, importantly, combined oral contraceptives have more contraindications than progestin-only. And the one that they've made over the counter is progestin-only. It is technically lower risk for side effects. So as far as a safety profile goes, it should broadly be applicable. However, the other problem with that is what we've already mentioned of the fact that it is slightly less effective, but we'll get into that in a second. We're not going to read through all of the studies. I can tell you, if we just want to talk a little bit about how do we assess if this is a reliable place to get information, Obstetrics and Gynecology is a very reliable journal. It's peer-reviewed and it's not a pay-for-play journal. You have to write a good paper and you have to have a good research setup to get published there, and it's peer-reviewed. Then you want to look at their methods, and they've got some methods here. This is probably not the strongest study that I've ever seen, but I do think it provides us with good information, okay? So what they've done is take a select group of people in El Paso, Texas. So this is not a broad study, but it is an interesting one. And they have given them a checklist so that they could be screened for level 3 and 4 contraindications to taking combined hormonal contraceptives. A 3 and 4 contraindication is something like the risks outweigh the benefits. And we get this data from a World Health Organization or CDC. Basically what they've done is given them a screening questionnaire that helped them decide, do I fall into a category of people where it would be less safe to use hormonal contraceptives? CDC has great data on this, and I love this chart. I think this chart is very useful and easy to understand, although it looks very confusing and hard to understand at first glance. But you can see why they wouldn't be able to just give somebody this and say, okay, screen yourself, right? Because the average person is going to struggle with going through this and first understanding what it is, and second, actually screening themselves for safety of the medication. So when they say that they gave a questionnaire that helped these people decide if they fall under a level 3 or 4 contraindication, when you just glance at this chart, you're going to be looking for anything that is red or pink, okay? So they are offering a questionnaire to make sure people don't fall into categories where you are going to see red or pink here. What the red and pink mean is theoretical or proven risk usually outweighs advantages. And number 4, the red, unacceptable health risk, method not to be used. All right, so these are going to be things like you have cervical cancer and you're awaiting treatment, higher risk for recurrent DVT or PE, and they're talking about different ages. They have different types of contraceptives here. So this is for all different types of contraceptives, but we're only interested right now in the CHC, which is combined hormonal contraception, as well as the POP, which is a progestin-only pill. So we want to be primarily concerned with this one for the purposes of this study, but for the purposes of the recently approved over-the-counter progestin-only pill, you're going to be interested in this category here. So you want to be able to effectively screen yourself out from using birth control that is not safe for you. So this is things like current breast cancer, a recent history of breast cancer. You're less than 21 days from giving birth. Now, this is an interesting one, right? Okay, so that's a 4 for combined hormonal contraceptives and a 2 for progestin only. Why? Because the risk in that time period is a risk of blood clots. So that's what they're concerned about. And that risk of blood clots is primarily influenced by the estrogen in the birth control pill. So this number 4 over here for combined hormonal contraceptive is a number 2 for progestin only because it is not as applicable there. And you can safely use progestin-only contraceptives within 21 days of having birth, committing birth. That's right. I'm only phrasing it that way now. So you're wanting people to be able to screen themselves out of things that would make it really unsafe. So decompensated cirrhosis, risk of having blood clots. So see here, we don't care about this number 4 and this number 4, right? Because these two number 4s are for copper and levonorgestrel IUD. Migraine with aura is going to be a number 4 for the combined hormonal contraceptives. Although I will say that some of the data we have on this is not really supportive of that. It is still standard practice to recommend against using a combined hormonal contraceptive. Ages, smoking, right? So if you're over 35 and you're a smoker, it is not safe for you to use a combined hormonal contraceptive. Antiphospholipid antibodies and known lupus. So you have lupus, you have antiphospholipid antibodies. You should not be on a combined hormonal contraceptive. The reason is because the risk of blood clots. So a lot of these, risks really come down to blood clots. And then you've got drug interactions here, okay? So in general, birth control pills don't interact with very many drugs, all right? I know you've been told, and everybody believes, that taking contraceptives at the same time as antibiotics will make them not work. This is false for the vast majority of antibiotics. I'm sorry for breaking your bubble, but your friend who got pregnant because they were on an antibiotic actually just forgot a pill or had a birth control pill failure, wasn't related to the antibiotics. Now, there are exceptions to that. There are a couple of antibiotics which perhaps can be influenced by your birth control pills, and rifampin is one of them. However, it's not very often used. It's not the only one, but that's the main one. So that is my one rant for the day, and your antibiotics not going to make your birth control pill not work. All right, so we've discussed now what we're looking for, and let's go through the study and see how well could they screen themselves for safety of being on a combined hormonal contraceptive. And I'll continue to remind you that this is not the pill that they introduced. This is a slightly less safe version that they're talking about here. So they gave them a checklist to decide if they were a level 3 or 4 contraindication. Now you all know what that means because we looked at the MEC chart, and they went with the World Health Organization MEC. We looked at the CDC one. They are essentially identical. They were then interviewed by a nurse practitioner who also measured their blood pressure. Self-screening for contraindication to oral contraceptives using a medical checklist is relatively accurate. Unaided screening is inaccurate and reflects common misperceptions about the safety of oral contraceptives. So they're saying that this study, which again is small, is saying that they need to be aided by taking a blood pressure by like a nurse practitioner. Okay, so this is probably one reason that we have not yet got to the point of having combined contraceptives over the counter. However, there are studies that indicate that this is not necessarily the case. So they're comparing unaided self-screen, which is just basically saying, like, do you think you're safe to take them, versus true contraindications using a checklist. That's their aided, not necessarily just taking the blood pressure. So the sensitivity of the checklist to detect true indications was 83% and specificity was 88%. Using the checklist, 6% of women incorrectly thought that they were eligible for use when in fact they were contraindicated, largely due to unrecognized hypertension. Okay, so the most common reason that somebody would say with a checklist, I am able to take this, is because they had hypertension and they didn't know about it, which they decided was due to them not having known about it. But there's some argument here that if your blood pressure is just high when you are in part of a study and this nurse is coming along and taking your blood pressure, that perhaps you might have an elevated blood pressure because you're a bit nervous to be included. However, it's a valid criticism. Let's continue on because there's more studies on this. But basically, they've said here that with aided screening, meaning a checklist, you can safely decide. And this is for combined, okay? So this is adolescents and young adults self-screening for contraindications to contraception. And this is a little bit less interesting, but they're basically saying some people think that age plays a factor of how well you can self-screen. I don't know that I've ever heard somebody say that. Most of the time, I think even people who are relatively young can effectively self-screen. I'm going to search around for a bit and see if we can find a few more of the studies, because this has been very thoroughly studied. This is ACOG's statement on it. And again, this is a statement that was made prior to the FDA approving this. So ACOG does a lot of advocacy for helping to kind of get these things pushed down the line. And this is one of the missions that they've had for a bit of time. They're talking about barriers to access being one reason for inconsistent or non-use. And we talked about that earlier, and I do think it's very important. They go over the fact that multiple studies have shown that people are able to use self-screening tools to determine their eligibility, and they have expanded this committee opinion recently to include not only oral contraceptive pills, but vaginal rings, contraceptive patches, and the depot shot. They think that those should all be available. So here's the recommendations and conclusions from the American College of Obstetrics and Gynecology. They support over-the-counter access to hormonal contraception without age restrictions. The without age restrictions comes from the study I just showed you, where it didn't matter on your age. You could effectively self-screen, particularly with a checklist. Over-the-counter access has continuation rates of hormonal contraception comparable to prescription-only access and has a potential to decrease unintended pregnancy. People want this, duh. Progestin-only hormonal methods are generally safe and carry no or minimal risk of VTE. VTE risk with combined is small compared with the increased risk of VTE in pregnancy in the postpartum period. That's what we had talked about just a bit earlier. We'll talk about this screening concerns, and they're saying, yep, all the things we've said. Now, this pharmacist-provided contraception, I take issue with that because I don't think we should make pharmacists do this. I don't think that it makes sense to have pharmacists prescribing birth control. Not because I don't think a pharmacist is capable of screening and prescribing it, but because that is an unnecessary step. And pharmacists are busy. Like, why put that on them if we can say, like, this is safe? We have data that indicates that it's safe. So there's no argument for that. It is silly to add to a pharmacist's already busy day to also make them have a consultation and write a birth control prescription when we have argued in this entire thing that it is a safe over-the-counter option. So I think what ACOG says in here, and I haven't read this in years, but I think what ACOG says in here is basically like, that might be a good step in the right direction to remove some of the barrier, but it doesn't make sense to have that be like the end goal. The end goal should be over-the-counter use. All right, so another common concern that people have when we talk about this is, okay, well, if you don't have to have a prescription, then nobody will come for their annual screening. This is a multifactorial problem for me to use as a reason that people shouldn't be on hormonal birth control. First, we have to address, okay, let's pretend that that is accurate, that you won't come and get a pelvic exam or pap smear or breast exam or whatever it is that you need if you don't have to get a prescription for your contraception. All right, let's pretend that's true. If that is the case, is it ethical then to withhold something from someone purely because withholding it might mean they come and get something else that they need? I don't know an excellent way to make a comparison for this of what would be similar, but I would argue, and I'm open to input, that holding people's contraceptive pills hostage because they need routine screening is not really an ethical stance that I would agree with. I just can't think of any other situation where we do that. Yeah, anyway, let's look at this data real quick. We've talked about it likely not being ethical to withhold somebody's birth control pill just because you think it might increase the chances that they come to have additional screening like pap smears or breast exams. Now let's talk about the fact that that's not even necessarily the case. So this study comes out of a journal called Contraception, which is also a reliable journal, study design, relatively small, but decent enough in that you should have reasonable belief that the results are at least broadly applicable to the population which it was studied in. So this is comparing people who got their birth control pills from a U.S. family planning clinic, which means they had to go in for a visit and have a prescription, versus over-the-counter pharmacies in Mexico. Okay, so commonly people who live in the U.S. and have ability to cross the border, they can cross the border and get contraceptives there without a prescription. Because of the chart we looked at earlier, it's over-the-counter in a lot of places. Then they're going to self-report whether they've had a pap smear in the past 3 years or a pelvic exam or breast exam or screening for STI. And there's some problems with that as well, because oftentimes people will self-report having had a smear and what they've actually had is just an exam for something else. But regardless, results suggest that most women would obtain reproductive health preventative screening if oral contraceptives were available over the counter, and highlights the need to improve access to preventative screening for all low-income women. Okay, so it's not just this study, there are many studies on this, but basically what we have now decided is, okay, great. Not only would it be unethical to withhold contraceptive because of that, it also doesn't help. People don't have a higher chance of having been screened or a lower chance based on whether or not they were given a prescription for a contraception. So this is one of the reasons that historically I have always said I really support the places like NewRx and various prescription birth control access apps and websites, because I think that it should be over the counter because it's safe based on the data that we have with a self-screening checklist. And I think that those places where you can easily get access without having to physically make an appointment and go into a doctor's office helps to avoid these delays in getting your prescription renewed and helps to avoid lapses in your prescription because you couldn't get into the doctor to get it refilled, or you forgot to go to the pharmacy, or the pharmacy didn't have the prescription, or they were out of the one that you had been prescribed, or whatever. These apps all make it so that you are much more able to avoid those problems. So in the absence of being able to completely get the pill over the counter, I do think those are good options as well. Okay, so we talked about the reason it is important to have hormonal contraceptives accessible over the counter. We talked about the risks of the hormonal contraceptive and the fact that we know people are able to fairly accurately self-screen to see if they are a good candidate to use hormonal contraception. We talked about the fact that not only would it be unethical to not make that over the counter for the purposes of withholding a prescription because it might increase the chances of somebody getting a pap smear or other screening, but that we don't really see that play out in the data when we look at how often people get screened and things like that. I think now we should talk about the benefits of it being over the counter. Now, we talked, mainly about access, but I also think that there are social benefits to this, just in that people have more access to have more control over their life. Every benefit of contraception, from life planning, pregnancy planning, the outcomes that we see with families having access to be able to do family planning, all of these things are going to be improved with improved access. And you're going to see a decrease in the need for abortion as you increase accessibility of contraception. So all of those things are benefits. Now, let's talk about what the FDA has recently done. U.S. regulators have approved the first over-the-counter contraceptive pill. It is not age-restricted, and it's a once-a-day pill called Opill. It is a norgestrel birth control pill at looks like 75 microgram dose, once a day, at the same time, every day. So we need to talk a little bit about that and why some pills are more sensitive to being taken at the same time each day. They're going to sell it over the counter, available in stores and online in the first quarter of next year. So this goes into play in January of 2024. Still a bit of time now to allow well-funded organizations to file a lawsuit against it. Today's approval marks the first time a non-prescription daily oral contraceptive pill will be made available for millions of people in the United States. When used as directed, daily oral contraception is safe and is expected to be more effective than currently available non-prescription contraceptive methods in preventing unintended pregnancy. This is an important point when we're talking about the failure rate of contraceptive pills combined versus progestin-only, that all of them are more effective than what you can get over the counter at the moment. Side effects. FDA talks about side effects here. Common side effects include irregular bleeding. That would be the most common side effect. I see that really, really commonly. Headaches, dizziness, nausea, increased appetite, abdominal pain, cramps, or bloating. Roughly 1 in 4 U.S. women who had ever attempted to get a hormonal birth control prescription reported difficulty doing so, often because of language barriers, lack of insurance, or costs. Yeah, that's important too, right? Because it's not free to go to the doctor in the US. It's not even cheap or easy. And if you are low income and you don't have insurance, even just being able to get to a doctor to get a prescription is a huge undertaking. And I think that the benefit we didn't talk about when we were going over the benefits of making contraceptives over the counter, or at least some of them, is that there is equity in this, right? Equality is not ever going to be fully achieved, but there is something about this that makes it more equitable, because if you're not required to have insurance and go to a visit, it still is going to be a problem because it costs money. Hopefully it will be an affordable price, but if you can't afford to go to the doctor because you don't have insurance, which can be hundreds of dollars or more, then being able to buy it over the counter is very important to you. Under the Affordable Care Act, they're required to cover preventative services, including birth control, but not over-the-counter methods, and they're committed to ensuring that it is affordable. There's no reason that it shouldn't be able to be made affordable. This is a very old medication. All right, so the way that they work, combined hormonal contraceptives work to prevent ovulation. The primary mechanism with which progestin-only contraceptives prevent pregnancy is by thickening the cervical mucus to keep it from allowing sperm into the uterus and up to the fallopian tubes where it might meet an egg. In some people, it does also prevent ovulation, but that is not the primary or intended mechanism of pregnancy prevention. Because this is the method of prevention, it is more sensitive to alterations in your blood levels of the medication would quickly allow fertility to return. Does that make sense? So say it works for 24 hours or whatever. If you miss it by a few hours or sometimes even an hour, you can have an increase in your pregnancy risk because you have a rapid change in the level of progestin circulating in your body, which allows for a continual production of cervical mucus, which now is going to be a different consistency than what it was before. Whereas with a combined hormonal contraceptive, you are preventing ovulation, which only happens at one point in the month, right? So when you miss one pill, your hormonal changes are unlikely to be enough to allow you to ovulate. So the difference is in the effectiveness rates, which, to be fair, we haven't fully teased out in data whether it's actually less effective or not, but it would make sense and follow to reason that with the changes being more immediate when you miss a pill or you're late for a pill with the progestin-only, that it would leave more room for error or confusion. Like if you're ever late for or you miss a pill, then you should use a backup form of contraception. Okay, here's a review specific to this pill on effectiveness. So this Norgestrel 75 micrograms is the one that they've just approved for over-the-counter use in the US. And they say that this is published in Contraception. It's a relatively recent publication. This is a meta-analysis, which is a high-level review. And they said they found 13 studies on this specific medication. They were overall not the best studies, but they still wanted to look at them. They used data from 3,000 women who were not breastfeeding. That's important because when you're using a mini pill or progestin-only pill while breastfeeding, you have an additional layer of protection for pregnancy just by the nature of being less likely to ovulate while breastfeeding. And they followed them for 35,000 months. And the range of overall failure during typical use was from 0 to 2.4 in 100 woman years, giving an aggregate Pearl index of 2.2. 7 additional studies involved 5,000 women of whom were breastfeeding, and their rates were 0 to 3.4%, and they were unable to calculate an aggregate Pearl index. The data supports that Norgestrel is highly effective in clinical use with similar failure estimates in breastfeeding and non-breastfeeding women. Okay, well, that's an interesting point. I expected something different from that outcome. And it provides support to the case for approval without needing to see a healthcare provider. Okay, so there you go. That's your failure risk is around 2.4% with typical use. So that's a fairly effective, and these are not on people who always get it right, always take it at the right time. You know, they're humans too. So you should have a goal of taking it at the same time, using a backup form of contraception if you're more than an hour off from that probably, and know that your chances of pregnancy on this pill are, around 2%. All right, here we go. This is the current recommendations for when starting. This is a combined pill, not a progestin only, okay? So backup contraception. If you are over 5 days from the onset of menses, then backup contraception is advised. Most patients are advised to use an additional non-hormonal method for the first 7 days of the cycle. Patients taking Dianogest are using for 9. Basically, if you are already well on your way to producing a follicle to ovulate, which if you're more than 7 days past your start of your last period, that would be the case, then you probably need to take backup contraception or use some kind of form of backup contraception for quite a while. Now, if you start it immediately on like the first day of your period, then in theory, that one should work immediately because you're not moving towards ovulation yet, right? So that's what they're saying here is that you don't need it like you do when you start it on like immediately the day it was prescribed. Can be started within 7 days following abortion or miscarriage, and you need it for 7 days unless you start it immediately after. So this is for combined hormonal contraceptives. So usually people would say to use backup contraception just across the board, right? Because if I'm counseling or if I'm talking in an educational sense and I'm saying what you should do, it would be more sensical to have a few people who don't need backup method to use it rather than a few people who did not to. But if it's you and you're individually going in to talk to your doctor, you should talk to them about like when was your last period versus when you're starting the medication. And then we'll do the same thing for progestin only. So if you start on the first day of your period, just like with combined, then you don't need a second form. And they say for within the first 5 days of starting your period that you should be fine without using a alternative form of contraception. That being said, because of the way that they work, this is kind of the part where I was saying earlier that in some amount of people, you do actually have a lack of ovulation on progestin-only pills. And so that's why they include this, like the first 5 days thing. Because if it truly was only thickening the cervical mucus, then you wouldn't have that, right? It would just be how long does it take to actually start affecting the cervical mucus. But because there's also a secondary effect of, in some amount of people, decreasing the chances of ovulation, you also want to pretend that it's going to do that, hope that you fall in the category that it's kind of dually affecting it. So yeah, you can start it any day as long as you're reasonably certain that somebody's not pregnant. And backup contraception is needed for 2 additional days if the patient is over 5 days from the onset of menses. So 2 days of backup contraception. And the reason that it's different as far as how many days here, so it says 2 days here versus in the last one, I believe it was 7, is because of the difference in how they work. It's going to take me forever to get back to that. But does that make sense? Difference in how they work is why there's a difference in how long, you need backup method.